Laura. I'm a fourth year medical student, and Dr. Ajalogba has kindly helped me supervise this presentation, and he has reviewed it. So hopefully, shouldn't be saying anything that's not true. But he's also here in the meeting in case anyone wants to ask him questions as well. We're just gonna start now. Um, So we're going to go through a series of cases from respiratory, GI, neuro, renal, and non-accidental injuries and MSK as well. So this is our first case. There's a child who presents with fever, cough, tachypnea, and reduced feeding. He's 2 years old, and he has intercostal recessions on examination and reduced air entry on the right side. So what do you think? What investigation should we do? And what are people thinking of in terms of diagnosis? If anyone can put any ideas in the chat, that would be great. Chest X-ray, yeah. Thank you, Joanna. So here's a chest X-ray, and this is an AP view. Usually in adults, we would do PA views unless they're severely unwell. But usually if children, they're quite small and they're hard to place them and keep them in position. So we often do AP views on them. But yeah, can anyone describe where the abnormality on this chest X-ray is? So if you kind of start looking by the midline and then compare the two sides. Yes, someone said right lower zone and right middle lobe. So that is the area there. Can anyone think of a diagnosis for this? I saw someone typing, so just feel free. So Simon has given us a few options: lobular collapse, infection, aspiration, and blocked bronchus. Do you think there's anything that is more likely given the patient's history and the imaging findings? So, yeah. Yeah, infection and history of fever suggests infection, exactly. So, what we would say that this is a lobar middle lobe pneumonia. So instead of lower lobe, it's actually the middle lobe. And so how, and I think someone said right middle lobe as well. So the way you would tell if it's lower or middle zone is what is it that you're losing in the image. So if you're losing the loss of the hemidiaphragm, which is at the bottom of the image, then that's lower lobe. However, we can still see the outlines here. If you can see my cursor, you can still see this outline. So that means that the hemidiaphragm is actually not lost. However, the cardiac margin here is a bit lost. You can't really see it properly. So that's how you would know this is middle lobe instead of lower lobe. And so, yes, we would call this a consolidation. And it's just middle lobe pneumonia in this child. I hope that makes sense. And if anyone has any questions at any point, feel free to ask. So our next case is, let's imagine that this patient actually presented slightly differently. So they had a wheeze, they have a hyperinflated chest and minimal fever. And they've had this before many times. What kind of diagnosis would you be thinking of in this scenario? The patient is still 2 years old, but with a slightly different presentation. Okay, so far asthma is an idea, and I saw someone else typing as well, so we can just wait for some responses. So, in a patient who's 2 years old, would you be thinking of asthma, or maybe, or have people got any other idea? Because in pediatrics, we usually say asthma comes if you're 5 years or older, I believe. Bronchiolitis, yeah. So that is a better answer for this presentation specifically. But if the child was, say, 8 years old, then asthma would definitely be a very good differential. So we took a chest X-ray, and what can you see in this image? Any ways you could describe bronchiolitis or the chest X-ray here? So Simon said linear atelectasis, peri and infrahilar regions. Yes, anyone else want to add something to that? Okay, if not, then. So yeah, the perihilar streaking is this these parts here that you can see. Um, so you can actually see parts of the bronchi, and that's what would be what the perihilar streaking would be. And you can also see that the diaphragms are more flatter here compared to the previous image we had a few slides ago. If I go back quickly, you can see that they are nice and round here. However, in this case, uh, they are more flat. And you can also see hyperinflation of the lungs here. This would be a typical picture of bronchiolitis in a child. I'm going to move on to a gastro case now. So we're talking about a very small baby, a 6-week-old male, and the infant presents with projectile non-bilious vomiting. And after feeds, the baby still appears to be hungry and has lost weight. While it's normal to lose a bit of weight once you're born, this has been a bit more in this kid, and he's 6 weeks old. Is there any diagnosis you're thinking of? Okay, so Phoebe said pyloric stenosis. That's a very good idea. So that is the answer. And is there any investigation you would particularly use for this condition? If anyone has any idea what's the like gold standard imaging? Some ideas are coming in. Yeah, so barium study, fluoro, and contrast swallow study could be maybe for some other cases, but ultrasound is the gold standard investigation for hypertrophic pyloric stenosis. So here you can see the hypertrophic pyloric stenosis. Does anyone know what this sign is called? And or if anyone knows the diagnostic parameters? Any idea about that? Okay, so we've had a few ideas. So this is a target sign or a donut sign, as you can see, especially here. And one of you mentioned bird beak or bird beak sign as well. That's more common in when a vascular structure looks like a bird's beak, and it's more likely an obstruction or volvulus. So yes, this is a donut sign or target sign that you can see here. And some diagnostic parameters are that the pyloric muscle length needs to be at least 4 millimeters or more, and the pyloric canal length, which would be here, has to be 16 millimeters, because you might see the donut sign, but if you don't see it, then it's important to know how to measure it. So those would be the measurements that you would use. But yeah, good job, everyone. And here's another picture of it. So this would be one of the measurements, and then the muscle thickness is another one. And what do you guys know about this? Is this a radiological emergency? Any ideas? Is this something you would classify as a radiology emergency? Not really. If there are signs of dehydration. Yeah, so I think Simon's on the right lines. It's not actually a radiological emergency, because before you can do anything about it, it's mostly the biochemistry that needs to be fixed. So I think in a lot of questions that we can do, like on Passman and Quasman, it always comes up that it's like a hypochloremic, hypokalemic metabolic alkalosis. So before you can do any type of surgery or correction, the biochemistry is the main emergency. So yes, that's the emergency, but it's not actually a radiological emergency. So what if the patient presents slightly differently? If the vomit was bilious and sudden onset, and also with some abdominal distension, then what other diagnosis would you be thinking about? Okay, so we've heard obstruction and malrotation. So those are actually very good answers. Um, Malrotation is the one that you would be most worried about. So here's a picture where you can see how the gut is rotated, and the small intestine should be here normally, but then here it's all twisted around. So this is an upper GI contrast study. Do you guys think this image is normal or abnormal? Yeah, so Phoebe said abnormal. Good job. Yes, it is abnormal. Does anyone know how we would call this sign? I'll put up here yeah. Does anyone know what this is called?
May I interrupt?
Yes, please. I think
Okay.
the other image is not coming up.
Okay. Before I'm just this image here, you can see the arrow, the black arrow. The black arrow is highlighting the duodenojejunal junction, and it's at the level of the pylorus. So if you look at the spine, and you can see the vertebrae, to the right of the vertebrae is the pylorus and the duodenal bulb. Then as it comes down, the vertical section is D2. Then it crosses to the left. That is D3. And then that comes up the way on the left side of the spine. That's D4. So the arrow is highlighting the duodenojejunal junction. So this is a good study, but this is a normal study. So the next picture, we'll see the difference.
Yes.
No, not this one.
Not this one. Yeah.
This is
Hmm.
second upper GI.
Yes, I will reshare my screen because it has disappeared for a second, which is
Okay.
very odd because it was there before.
Yeah.
Sorry. Mm, okay. Hopefully you should be able to
Brilliant.
see my
Okay.
image now.
Okay. Now, if you look at the second image, you can see that the second image, please. You can see the NG tube in the stomach, and now it's moved into the pylorus and proximal duodenum. Now, if you compare the two pictures, on the right-hand side, you see dilated duodenum. D3 did not cross, it's not crossing across to the left. Instead of going to the left and going up, it's corkscrewing down the way towards the right. So this is abnormal. This is malrotation with volvulus.
Yes, so this is the abnormal study here.
Yes. I'll pass it back to you now.
Yeah, thank you. I don't know why it didn't appear, but hopefully you can carry on. Um, so here we can see something slightly related. So an abdominal X-ray, and I believe you can see the double bubble sign here, two bubbles, and this is usually associated with duodenal atresia. And we're bringing this here because sometimes the presentation can be slightly similar. But my main question is, what syndrome is most likely associated with duodenal atresia? Does anyone know? Downs, yeah, so good job, Sean. That is absolutely correct. And now we will move on to the next case. So this is a neuro case, and it's about a child who is 3 months old, and they presented with rapidly increasing head circumference and a bulging fontanelle, and also with poor feeding. What diagnosis would you be worried about in this patient? We've had bleed, hydrocephalus, and hydronephrosis as ideas so far. So hydrocephalus. Oh, thank you. So hydrocephalus is the right answer. I understand how bleed could have come because bleeding can also increase the intracranial pressure in someone's head, especially a baby, and they can also present with poor feeding. However, with the rapidly increasing head circumference, we're more likely thinking about hydrocephalus. And encephalitis with swelling, I believe that's a good differential as well, but maybe hydrocephalus is more likely if you have an increase in head circumference. But Dr. Ajalogba, please correct me if that's not right. Um, yeah,
It's a good differential, yes.
okay, thank you. So this is a cranial ultrasound scan, and this is normal. Can anyone tell me what we can see here, like in the middle? Lateral ventricles. Yes, so this is something that we need to look out for in a cranial ultrasound scan, especially in a patient who has suspected hydrocephalus. So in hydrocephalus, this is what it actually looks like. You can see that the ventricles are much more dilated, and you can make measurements as well. There's dilatation here and here as well. And this is a different view, I believe, a sagittal view. Yes. So you can see it's much more dilated compared to the previous image, which is here, where they're quite small and you can't see the horns as well. However, Sean mentioned encephalitis and swelling. So it's very important to think about inflammation and infections as well. So another differential could be meningitis and ventriculitis. And here's imaging of that as well. You would have less of the diameter of your head increasing, but the symptoms could be quite similar. And this image here has a characteristic view. Can anyone tell me what this sign is? What does it look like? So this is the sad face. Oh, oh, sorry, Sean's typing. But yeah, so this would be a sad face. You can imagine the ventricles. These are the eyes, and then this is the mouth. And here you can see the star sign as well in the middle. So this is how you could be differentiating from hydrocephalus. It's the different ventricles that are being enlarged there.
If I may interrupt again, you have a lot of information. Okay, you're absolutely correct in calling it a sad face, but this is also a subtle sign of hydrocephalus because in this image, what you can see are the temporal horns of the lateral ventricles. But because the way the image is obtained, we can see the temporal horns and they are dilated, they look sad, the whole face looks sad. So it's a subtle hydrocephalus that you see in inflammation. Okay.
Thank you for
Thank
that.
you. So,
Yes.
yeah.
And then if you have raised intracranial pressure, you would also be thinking about space-occupying lesions such as tumors as well. Can anyone kind of tell me which part of the image has got the tumor on here? Cerebellum. So yes, this is here the area where you could see the tumor. And again, here you can see the ventricles, I believe, are slightly, and the temporal horn is also slightly enlarged, as the tumor is squishing everything, which is making the CSF flow back into the ventricles as well. So it's important when a patient presents with problems such as reduced mental state and swelling of the brain that you think about these three things. So it could be hydrocephalus, it could be a space occupying lesion, or it could be inflammation. So these are the three things that categories that you would think about and try to rule out. So let's imagine that this patient actually came with slightly differently. So the patient comes in, they're still 6 months old, but they have seizures, slurred speech, and an unsteady gait as well. And when you examine them, you see that the face is stretching, and the mom says that the face didn't look like this just a few hours ago. What are you thinking of in this scenario? Yeah, so stroke is the right answer. I think many times with stroke, we think about older people, but it's very important to think about pediatric strokes as well, as they can be very damaging. So a pediatric stroke, what we would do is a non-contrast CT head and angiography. So this is the A and B images show the non-contrast CT. You can see that the stroke is where the arrows point. So that's where the occlusion has happened. And then you would also do angiography to identify where exactly the problem is, and then hopefully correct it as well. So that would be here. You can see that the vessels are not connected anymore on angiography. And I think Dr. Ajalogba has something to say as well, please.
Okay. It's a very subtle correction. The images that you're looking at are MRI images. The images we discussed initially were CT images, but these ones are so beautiful that we used this one. So these are MRI images, and the A image A is the T2 axial. Image B is the diffusion weighted imaging, which is showing the area of low signal. That's the area where there's a stroke. DWI, or diffusion weighted imaging, is great in acute stroke. And then the image C is the angiography, MRI angiography. Okay, so essentially, Laura is showing you the panacea of imaging modalities that can identify stroke and also demonstrate the beauty of radiology. I'll pass you back on to Laura.
Thank you. And thank you for the correction. Yes, I just forgot we were trying to find a CT, but an MRI was so much better. And I think that usually happens with brain imaging in children as well, that acutely you would do a CT, but then just a bit later or a few days later, an MRI shows the difference is much better. And I think Dr. Ajogba, you might be the better person to answer this, but someone has asked, would you do a mechanical thrombectomy on children in this scenario?
In the right center and in the child, yes, it has been done in children and slightly older children, not in toddlers, but slightly older children, yes. But it has to be within the therapeutic window, and you have to get the child to that center very, very quickly.
Thank you. Does that clear it, Nahid? Oh, thank you. Okay, perfect. Thank you. So we're gonna go on to our next case, which we called baby massage. So this is very common that would happen in a pediatric case, but a parent felt an unusual lump while holding their baby or, massaging them. So the age is 1 and there's an abdominal mass felt, and we can see people have already put in ultrasound would be the investigation that you would do. So that is the investigation of choice. And before I go on to my next slide, has anyone got any ideas what kind of masses could you feel in babies of this age? Wilms tumor, hernia. Yes, so those are great ideas. I think Nahid is saying something. We can wait for that. Not sure. So ultrasound is the correct imaging. And here we've just put in a few images of different things that you could find. So you could find a nephroblastoma. You can see the yellow arrows pointing there. And you could also see a hepatoblastoma, which is quite big. And then if you put on the ultrasound to see the flow as well, then you can see that it's vascular. And then a neuroblastoma as well, which I think is quite subtle. But yes, so the mass would be around here. But it's very important that in this age of babies, you would do an ultrasound scan to get them least radiation possible, and also because it can give you an initial idea of what you're looking at, and it's really good for that. And then sometimes they will do follow-up CT imaging. However, if you don't know exactly where it is, what it is, then an ultrasound would be the first line imaging that you would do. So we're going to move on to our next case. So this is about a 6-month-old girl, and she presented with vomiting, lethargy, and reduced GCS. And in her history, we were speaking to the parents, and they said that she fell off the sofa 3 hours ago, and she has fallen about 30 centimeters. So what investigation would you do? So yeah, I already can see some responses. CT head scan with because of possible bleed, CT head. So yes, that is a great answer. And what can you see in this image? Yeah, perfect. So you can see subdural hemorrhage, And the question is, so you've answered that very well. And it's important to know that in an acute setting, CT is the best to figure out what's happened. And they could have a skull fracture as well. But yes, in this scenario, this is just a subdural hemorrhage. So what other investigations would you do in this patient? Is there anything that's ringing alarm bells? SPA, skeletal, surgery. Any other ideas? Yeah, so skeletal survey is definitely a good answer, especially given the scenario that the patient has fallen from 30 centimeters, which is not that high, and you would be worried about if there's anything else going on with the parents there. However, the imagings that you would firstly focus on is, so you've had your acute CT had, which is here, and you can see that there's subdural hemorrhage and there's a midline shift, so the ventricles have moved. And you would also use skeletal survey to look at other fractures, but we're going to come on to that in a moment. But another imaging that you could do is MRI brain. And this is because you want to assess for retinal hemorrhage, which can be see here. It's quite subtle, but it's basically there's an extra black dot coming out of the back of the eye. So this is what you could be see. And here's different images of MRIs as well. And MRI is really good to image a few days later, or also to follow up any changes that the damage has caused. Because if a child has at such a young age a subdural hemorrhage, it's important to follow up to see if what kind of damages has been done to the brain. So you can see that there's some parenchymal injury here on the sides. It's a bit subtle, but yes. And then these images also show a follow-up, and you can see that there is actually extra space and extra axial spaces because some tissue has been lost um, following this episode. So skeletal survey, as you mentioned as well, that's something that you would also think about in this scenario. And what can you see that would be indicative of child abuse? I appreciate the images might not be the best, but what are the typical findings that you would be looking for in a patient who has potentially suffered abuse? Rib fractures? Yes, exactly. So that's what you can see in these images right here, and here as well. Any other things that you might see in a patient with a non-accidental injury? Yeah, so remodeling old fractures, fractures of different ages. Yes, because that could mean something that's been going on for a while, and that the patient has an injury from before and then now from later, and they're in different healing stages. So yes, that's a very good answer. Oh, my answers have gone. However, here are the answers. So what you can see is rib fractures, especially posterior rib. That's because the patients are unlikely to fall on their. It's very hard to injure in a child of this age, especially if they're 6 months old. They're not really going anywhere. They're mostly crawling maybe a bit around, or they are in a rocking chair. So it's very hard to get those type of fractures. Metaphyseal corner fractures as well. And as you mentioned, fractures at different stages of healing. So thank you. That was very good. Then we're going to move on to the next question. So we're going to do an MSK question, kind of linking in, but let's imagine a completely different child. So this is a 4-year-old boy who presented to A&E with his dad, and he's been limping. And he's been complaining of having hip pain, and also they had a low-grade fever, and there's reduced range of movement at the hip. So what investigation would you order? Okay, so we have a few ideas here. Pelvic X-ray, yeah. So a few different ideas. Transient synovitis, septic arthritis. So what you would do is an AP pelvic X-ray. And I can see some answers and differentials which are along the great good lines. But before we get on to that, can anyone identify where is the abnormality in this image? Sorry, one requests a radiology investigation and doesn't order. Yeah, let's not be mean to radiologists. So yeah, someone mentioned right hip. So yes, if you look at there, then you can see that there's a flattening of the femoral head and there's increased sclerosis as well, especially in this area here, and fragmentation as well. So you've already mentioned, some people have already mentioned differentials, but what is the main diagnosis that you're thinking and worried about right now? So we've had Perthes disease and transient symptomitis, septic arthropathy. Is there a final answer that anyone can think of? Okay, so Perthes is one of the ideas. So yeah, that is the correct answer in this question. And here's an image showing what's happening. So the ball and the socket hip joint is the one that is affected, but as you can see, there will be avascular necrosis in someone who has Perthes disease, and that is what is causing the pain. So let's imagine that the patient presents slightly differently. They actually, instead of having a low-grade fever, they have a high-grade fever, and it's not only that they have reduced movement, but they cannot weight bear, and there's an acute onset hip pain. What investigation would you request in this scenario? Would you do the same investigation or would you change blood tests too? Yes, the blood tests are very important as well. Is there anything you're looking for on the blood tests? And then someone also mentioned aspiration. Infection, yes, and ultrasound to rule out collection. Any other ideas? High inflammatory markers. Yes, so definitely that what you're looking for is for infection and inflammatory markers on blood tests. But the main investigation that you would do in this case would be an ultrasound hip first. So can you tell me on which side the abnormality is? Okay, so we have right and left. Can anyone maybe think of a reason to back their opinion? So we've had right due to fluid level, and we've also had that some people think that there's fluid on the left. Um, Looking for some more opinions to see. Dr. Ajalog, would you like to kind of clear the confusion? in this scenario.
To clarify, very good presentation, Lara. To clarify the right image, you can see the musculature and the joint capsule distended by the black area. So that's a right hip joint effusion. No, there, go north, go move the arrow north into the black hole. There. So that's the effusion. If you compare with the left, there is no effusion. So that's different. So that's just, so with signs of inflammation and infection and fever, if you see these, the orthopedic guys are most likely going to aspirate to make sure there's no septic arthritis.
Yes, thank you. So yeah, just make sure if, as someone mentioned, that black is fluid, then try to concentrate on that and then find where is the extra fluid compared to the other side. So yes, it's on the right side, and you would take a sample of it. So yes, you would. And what is the diagnosis in this scenario? If you keep in mind that the patient is unable to bear weight and has got a high fever as well, and has got this large collection of fluid, what is the most worrying thing? Yeah, so the septic arthritis is what we're worried about. That's perfect. And so what you would do is do synovial fluid aspiration and draining the joint. So you would aspirate until it's dry and also think about arthroscopic washout. And in the meantime, you would also think about antibiotics for at least 6 weeks because this is an infection and it's in the joint, so it's very important to clear it out. So this would probably be done in collaboration with the orthopedic team and microbiology as well. So we're going to move on to a new case. We're going to forget about this boy and think about a 7-year-old girl, and she falls onto an outstretched hand and she presents with wrist pain, swelling, and reduced movement. What investigation would you consider? Yes, so wrist X-ray is the most popular answer, and that is the answer. AP and lateral, yes, that's very important to say, especially in our FUSH. So you can see here an image. What is it that you can see? So someone has mentioned possible scaphoid injury, and someone else has replied, Simon has replied that they're too young to need dedicated scaphoid projections. And then someone mentioned green stick fracture of radius and mid-shaft radial fracture. So yes, what you would be seeing is a green stick fracture right here. And it's an incomplete fracture, not the whole bone is fractured, only part of it. And the break is only on one side. This is because children's bones are very springy and they're not completely formed yet, so they're quite easy to bend. And this is what we would be thinking of. About the scaphoid, you're more worried about the mid shaft due to the way the patient has fallen, I believe, in this scenario. But it is important if you can't find any abnormalities on an X-ray that you can redo a scan a few weeks later. But I'm not sure how this works in pediatrics, but Dr. Ajalogba can help us out.
Yes, it's a very good idea to think about scaphoid, but in the X-ray that we're looking at, the scaphoid is not ossified yet. So when you look at the wrist, you can hardly see any bones in the wrist. So they are not ossified. So this is a very young child. The interesting thing is people have picked up beautifully the green stick fracture of the distal radius, but not one thing people are not appreciating, and that is why I'm paid lots of money. The reason I'm paid lots of money is because if you look at the ulna, it's bent, but not completely fractured. So we call it like a plastic bowing of the bone. So it's a subtle fracture, but there is no break. It's just bent, and it's very peculiar to pediatrics. So when you look at the two bones, both of them are fractured. One is just more fractured than the other. So you have bending or bowing fracture of the ulna and a green stick fracture of the radius. I hope that clarifies what we're looking at. So people say radiology is an art, not a science. And this is one case of it where you can spend days debating the subtlety of the X-ray. Back over to you, Lara.
Thank you for that. Thank you. So let's imagine that this girl has actually, again, fallen onto her outstretched arm. However, she presents with pain and swelling around the distal forearm this time, and also reduced range of movement. What investigation would you request now, and what views? Wrist X-ray still is one of the answers. X-ray wrist views first. If scaphoid ossifies sufficiently, then do the extra projections. So you would do an APN lateral X-ray of the wrist in this scenario. Can anyone tell me where the abnormality is? So some people have said right wrist and dislocation, Salter-Harris fracture. So you can see the abnormality here. So people have guessed that correctly. And you've already mentioned Salter-Harris fracture, so that is the answer. So it's a distal radius fracture which extends through the physis and the metaphysis. If this is the information that you know, then what Salter-Harris type fracture would you classify it as? I can just see some people still typing. So this is the Salter-Harris type 2 because the fracture is through the physis and it extends into metaphysis. And this is the most common Salter-Harris type fracture and usually has a good prognosis as well. Here's an image of the different type of Salter-Harris classifications, as you can see. So the first one is straight across the physis, then the second one is above metaphysis. Then we can see lower epiphysis, and then we can also see through metaphysis, endophysis, and epiphysis, and then the crush injury. So, yes. I hope that clears up. If anyone has any questions, then let us know. I'll just go back to the image so everyone can see it one more time. And I think Dr. Ajalogba is typing as well, if there's any comments. Dr. Ajo, if you want to unmute yourself, if that works better. I just saw you typing.
Right. Thank you very much. Beautiful description. I just wanted to say that if you think of a mnemonic, Salter is can act as a mnemonic. So you have type 1, which is slippage, like the Sufi you get in the hips. Type 2 is metaphyseal, above the physis. Type 3 is epiphyseal, below the physis. So that is Salter. So T, type 4, is true both metaphysis and epiphysis. And then type 5 is the most severe. That's an impacted or rammed fracture. So if you think of salt, then you can class epiphyseal fractures in children in that manner. So if the physes are fused, then Salter-Harris classification doesn't work. Then you classify them as an adult kind of injury. So it's just because the physis is very, very important in pediatrics. That is why physeal injuries are quite interesting.
Yes, thank you very much.
We'll go back to you.
And yes, so try to remember this mnemonic when you revise. So we made a bonus slide here, which is quite random after all the MSK that we've done. So if anyone can name any lines that they can see on this baby, that would be great. And also, as an extra question, is there something that is weird in this scenario? So someone has said NJ. So yes, you can see quite a few lines here that yes, yes, very good answers. So we can see an NG tube here. It's coming into the stomach. And then someone, yeah, Louise and Simon had both mentioned UVC. So it's going to the liver and is not sitting correctly, as you can see on this image, which is here. And it's going into the hepatic vessels, and that is not the correct position. So you shouldn't see this. It should just go kind of straight up. And if you want to differentiate between the umbilical artery and umbilical vein, usually the one which is called up, I believe, is the artery. But yes, so that's very good spotting there. Here's a picture again. So it should stop around here, as we mentioned before, instead of going into the liver. You can see the umbilical artery, which is slightly moving around, and then the UVC coming up here instead of coming into the liver, as we could see in the previous picture. And then here we could see the NG tube as well. So good job. And now we're going to slightly go over some cardiology. So there's a 3-week-old who presents with central cyanosis, poor feeding, tachypnea, and the oxygen saturations are 82, which is quite low. And when you examine the baby, there's a loud single-second heart sound and no significant murmur What investigation would you be thinking about in this scenario? So we've had ECG and chest X-ray, and I think those are both very good answers. And echo. So what we would do is a chest X-ray firstly, and I believe echocardiograms are mostly done by the cardiology people. Does anyone know where the abnormality is? Yeah, so tetralogy of Fallot is one of the answers. Enlarged heart, definitely you can see that it's quite big. Boot-shaped heart, very good. And ASD. Cardiomegaly. Yeah, so lots of answers. So this would be an egg on a string appearance. So this is quite historical, and this is how they would explain it to be previously. And you can see that the mediastinum has narrowed, and there's more pulmonary vascular markings, which you can see here and here on the side. But yeah, so they usually call this egg on a string, which I find quite funny because you need some imagination to come up with that. So this would be transposition of great arteries. And then tetralogy of Fallot is actually the boot-shaped heart that someone has mentioned. Fallot. I think the name is French, so technically you should be pronouncing it as Fallot, but I don't know. I think either way is fine. So yeah, here you can see that this is the boot-shaped. So you have decreased pulmonary vascular markings opposite to transposition of great arteries. You can see everything is quite dark. And in transposition of great arteries, there's increase of pulmonary blood flow, which is why the vascular markings are less seen. And then in tetralogy of Fallot, you have decreased pulmonary blood flow. So again, this is the way they used to call it a boot-shaped heart.
If I may ask a question of the group, please. Lara, well done. To the group, what are the components of tetralogy of Fallot? If you understand the components, you might be able to explain better the chest X-ray findings. Tetralogy, so 4 components.
If anyone's willing to name a few of them, that would be great. Good revision too. Someone mentioned septal defect.
Yes.
Overriding aorta.
Excellent.
Pulmonary stenosis.
Brilliant.
And VSD.
The pulmonary stenosis is why the lungs are oligemic. So because of the pulmonary stenosis, you have right ventricular hypertrophy, and then the only way the blood can get around the body is because of the presence of the VSD, and then the aorta sits right over the VSD. So well done to the group, fantastic. Who says radiology is boring, eh?
Exactly. And also, I think it's a common question in exams as well that pulmonary stenosis is the part of tetralogy of Fallot which defines how severe it is. So yes, it's very important to keep that in mind. So that's the end of my presentation. Images were used from here. And if you could please fill out this feedback form, that would be great because then I can prove that I've done it. And also for the future, we can improve sessions. And yes, so please, if you can scan the QR